Hello, everyone, and welcome to this special Q&A session with medical doctors, local medical doctors, that is, on the coronavirus. We welcome Drs. Delroy Jefferson from the HSA, Dr. Archita Joshi from Health City, and Dr. Stephen Gay from Doctors Hospital. I'm Donna Bush. I'm your host for today. We also welcome the media via Zoom, as well as our sign language interpreter, Miss Carolyn Powell. Okay, so we're going to begin with Dr. Jefferson. Welcome, Dr. Jefferson, to the panel. Let's begin by telling everyone out there exactly what processes the HSA has gone through as far as it relates to making sure that the hospital and the facility is ready for any patients who may come.
Thank you. Thank you very much, Donna, and thank you for allowing us this opportunity. I want to say on behalf of my colleagues who are here on the platform that it's indeed a pleasure to be able to address the country in this manner. On behalf of the fraternity, I want to say that it's really an honor. You see, we're hoping to bring hope to the community. We're in a very intense situation right now with this COVID pandemic. And fortunately, we've had various physicians within the various facilities coming together to plot a way forward so that the persons within the community could feel comfortable, could feel that there is hope. And also, today we're hoping to bring some sort of a knowledge to the community so that they can feel relaxed. Before I go into the flow, I just wanted to give the country some general information about where we're at as a country. We've had so far 66 positive coronavirus patients with coronavirus. Of this, well, the age range is between 14 and 85. Average age of 43, 53% have been males, and 48% females, and this is in line with what we see internationally. We've had 11 patients admitted so far. Fortunately for us, we've only had 3 patients who've been admitted to the critical care facility. 2 of whom were ventilated. All of the patients who've been in critical care on the ventilator, we've managed to get off the ventilator, and they're all doing very well. So as a country, we're doing fine. Now, the health sector has, as I mentioned before, has combined efforts. Now, we've had doctors from the Doctors Hospital. We've had doctors from the from the HCCI, and some doctors from the Cayman Islands Medical and Dental Society, who've together recognized that this is a sort of a war, and we have to pull forces together to get all the available armamentarium to attack this virus, and to ensure that we are secure as a country. The patients would normally, who normally present, will normally come to the HSA emergency room, or the patients may present at Doctors Hospital or at Health City. The patients would, depending on their presentation, depending on the severity of their illness, would either be triaged and sent home if they're mildly ill, or if they are moderately ill, kept in the hospital. Moderately ill meaning they need some form of support, hydration, or if they'll be needing some oxygen therapy, they'll be kept into the hospital at one of the facilities. Initially, it's intended for these patients to be kept in the respiratory unit at the HSA. There is currently a 5-bedded respiratory unit at the HSA. But that unit, if needs be, could go up to 7 beds. Once that is occupied, the patients will be seen at the Health City Hospital, or we're looking into now, well, we're currently very advanced in setting up what we call an alternate health site, an alternate care site off campus. The patients who require ventilation, require more advanced ventilator support, these will be kept in the critical care unit. We currently have at the HSA a critical care unit that's capable of providing ventilation for 7 patients. But that can be expanded if needs be, because we have enough ventilators on island to support currently 36 patients. And there is some program going on now to get additional ventilators at the HSA. So that's the initial aspect of it. I'm going to move to my colleague who will tell you a little bit more about what happens when we've moved beyond the phase of the HSA.
Okay. Dr. Stephen Gay?
Yes, and when we go beyond the HSA, they take the initial, they're the initial center for dealing with COVID patients. And they have a certain capacity to deal with ventilated patients or just hospitalized non-ventilated patients. And when that capacity has been reached, there's a spillover that goes to the Health City Cayman Islands. And Health City Cayman Islands then goes on to take up in their capacity according to their field. I think Dr. Archita could give us more information on the Health City situation.
Yes, thank you, and greetings to everybody. The phase 2 of a potential surge, if we see patients which are exceeding the capacity, patients who require ventilatory support, and the critical care unit at Health Services Authority is now full, Health City would be taking over these patients. So the ventilated patients or patients requiring ventilation with potential or suspected COVID-19 or confirmed COVID-19 would then be transferred to Health City Cayman Islands Critical Care Unit, where we have earmarked 11 beds in the medical intensive care unit for treatment of such patients. This includes 2 beds with airborne isolation rooms, which is what we understand as a negative pressure isolation room, which would be an ideal circumstance to have such patients in. This is the phase 2. So when the ventilation capacity or the critical care bed capacity is exceeded at Health Services, Health City takes over. In addition to this, there is also a provision where Health City has earmarked around 24 beds, which are ward rooms, 24 ward rooms, where we have central piped oxygen supply and a central vacuum, where patients with suspected or confirmed COVID can be housed. If they do not need critical care but do require hospitalization and admission to a ward level care, and the capacity at Health Services Authority is now full. So Health Services, I believe, has earmarked beds in their medical unit, where the patients who do not require critical care but do require oxygenation or management in a hospital would be placed after their respiratory care unit is full. And Health City similarly has earmarked 24 such rooms. Now, if there is a further surge and we are having a situation where we need more ventilated beds or more hospital beds, I'm sure both hospitals would be collaborating and trying to increase this capacity as we can. Just to make you understand, both hospitals do also have to reserve beds for people who are admitted or who come in for non-COVID related problems. So currently, I believe the surgical unit at Health Services and the first floor ward at Health City is reserved for such patients. And if there is a further surge, I'm sure both hospitals would be able to try and increase the number of beds that could be made available for COVID-19 patients. There is also a small provision to increase the number of ventilators by probably, if the situation comes to that, using some of the anesthesia machines. I believe Health Services has 4, and we have 5 such anesthesia machines which can be used as ventilators. And when this situation does arise that we are running out of beds with ventilation, we would be able to use at least a few of these machines for the purpose of ventilating patients with COVID-19. So these are the phase 2 and phase 3 plans. So, if the epidemic were to progress in on our islands, then this is what we can do.
That's correct.
Following which, I'm sure Dr. Gay would want to expand, because that would be the phase 4, where we are looking at where both the centers have exceeded their capacity, and then probably other alternative care sites or a doctor's hospital would want to pitch in.
Yeah, certainly when we get on to Health City Cayman Islands and Cayman Islands Hospital, getting to their capacity, we move into a situation, a phase 4 situation, as we call it, which is critical surge. And at that point, we certainly are in a zone that we hope to avoid. We don't want to get to that stage where we have exhausted the main health services and health resources. It occurs certainly. What I should say first is that the capacity of Cayman Islands Hospital and the Health City Cayman Islands together is about 27 patients for ventilated cases and 54 patients for non-ventilated cases. And the spillover, when further cases arise, will be going to a dedicated alternate care facility and the Chrissy Tomlinson Hospital. Chrissy Tomlinson's capacity as a 13-bed hospital is not great, but we certainly we certainly have 3 bed spaces that are dedicated for infectious disease with negative pressure rooms. And there are 2 anesthesia machines which can be converted to ventilators should the need arise. Outside of that, other patients that need hospitalization can go to the alternate care facility, as Dr. Jeff was pointing out. And should this happen, the situation will be dire. But the alternate care facility is the alternate care facility should have all the comprehensive aspects of care that are required in any other hospital. And we need all the nursing staff that you would have for these patients. You need support staff, so you need housekeeping, you need cleaning staff, you need porters, security staff, and dietary staff, dietary personnel, and so on. So in summary, this 4th phase is really a very a very critical phase where there are high numbers of cases coming in, outstripping the capacity of the hospitals, and indeed we don't want to get there. And it is indeed the reason why our leaders have actually instituted the isolation and containment measures that are currently in place. So this is at phase 4, things are dire, or we're concentrating on just saving lives, and we will be doing the best we can to do so.
Just for clarity, what phase are we currently at?
Currently, we're
this is phase 4.
very first phase.
Right.
We're at the very early phase, and we're hoping that that's the only phase we'll ever experience.
Right.
I am very optimistic. As my colleague Dr. Gay says, I mean, the government has put in a number of measures to ensure that we never move to phase 2 and 3. And from the look of things, I'm hoping, beyond all hope, that we remain the way we are. We've been very fortunate in the Cayman Islands. I mentioned earlier about the collaboration between the various hospitals. Never before have I seen this degree of coming together of the minds. We've had doctors from the HSA from the early onset. We had a team with Dr. Cummings and Dr. Lundy and a group of others. We've had doctors from the Health City. We've had doctors from Doctors Hospital, and together they've really come together to ensure that the literature of the most recent evidence is found. We're fortunate that we've had China going up before us, and we've had Italy, and we've had the United States, and we've seen and learned lessons from them. We've seen what they've done right and what they've done wrong. And we have a group, an army of physicians who are scoring the literature to see what's the best approach so that we can learn from the evidence that's now existing. We will stay in stage one, phase one.
Okay, that sounds like a very, very good plan. I'm going to move to members of the media to see if anybody has any questions at this point for the doctors. If not, then we will definitely move on. Anybody from the media have any questions at this point? Okay, we're going to go to Kayla from the Cayman campus. Kayla, go ahead.
Hi, how are you? Thank you for the presentation today. I wanted to ask about the patients that end up being hospitalized. What is the standard treatment that they're receiving? Are there any types of medication that doctors have found helpful?
Right. Thank you, Kayla. Thanks for that question. There are a number of measures a number of approaches that we're taking. We're going to be going into a little bit more details of the clinical management of these patients. Dr. Archita is going to be addressing some issues relating to the medical management of these patients in the next presentation. So hopefully your questions will be answered then.
Okay, we have a question. Go ahead, Kayla.
I also wanted to ask, do we expect to hear more test results during this presentation or later today?
No.
Okay. And I also wanted to ask about sorry, I'm just pulling up the question that came through to me. You know, doctors are advising people not to put off emergency treatment. How do we ease people's fears that if they really are in need of medical treatment, that it's safe to go to the hospital despite COVID?
So I'm sure this is a big concern, and this is not just here in the Cayman Islands, but world over. And we've been mentioning in the medical community, people don't stop having heart attacks or strokes just because there is a pandemic going on. So the advice to the general population is that if they do have, emergent medical concerns or they are having some acute symptoms, it is best to seek advice. The safest way to go about would be to call a hospital or call ahead and find out how they should address their symptoms. If these are some mild symptoms which can be addressed, by a physician advising them telephonically or otherwise, that's fine, but that can be done. However, for acute symptoms, like a severe chest pain or suspicion of a stroke or some kind of a major injury, it is best to show up at a hospital. And all measures are being taken at most hospitals to ensure the safety of the patients when they arrive. I can vouch for, at least my center, and I'm sure all of us have put into place infection control policies and procedures, which we will also be talking about shortly, to address and to maintain the safety of course, the patients who come in and also of our healthcare personnel. So most hospitals have defined zones where a patient with COVID suspicion or confirmation would be placed, and there are zones where people with non-COVID related issues who show up at the hospital would be addressed and treated. So I'm quite sure it's very safe, and just because COVID-19 is a pandemic right now doesn't mean we should neglect our other health concerns. There have been unfortunate events of late where we've seen people have delayed their treatment, and that has led to either permanent disability or poor outcomes in their management. So that's not advisable.
Thank you for the response.
Okay, we now go to Wendy from CNS. Wendy?
Thanks, Donna. Can I just clarify? I think it's hard to tell because we can't see people, but I think it was Dr. Jefferson that was talking earlier about the actual numbers and ages and things. Can I just clarify, because I couldn't hear very well? Did he say from age 14, as in a teenager, to 85? Is that correct?
That's correct.
Thank you. Can you give us a better indication as to the ages? Were, like, for example, how many of the people that have tested positive were over 60, for example?
I will get the breakdown of the various age ranges for you, and sent quite a. There were a relatively even spread. There was
All right, okay.
There was a relatively even spread. The ones who were presenting with the more severe illness were patients by and large over 50. But
Okay, and the ones that were sick, the patients that have been sick, do most of them or any of them have underlying health conditions?
quite a few. That's
Okay.
what we've found. So for all the 11 except for one particular case, for most of those who were admitted in hospital, they've all, except for one, have had significant comorbidities. They've had significant issues relating to hypertension, diabetes, some pulmonary problems. But
Okay, so we're similar to most other countries.
That's correct.
In the world in that respect.
That's correct.
Okay, I'm not sure whether this would also be part of a sort of epidemiology question, I suppose. As physicians, you're obviously studying this, you're looking at the patterns and the shapes, and obviously we have low numbers. But do you believe that we were just lucky enough not to have that many people with the virus when we actually began to lock down? Or is it because we've locked down that the virus is spreading very, very slowly? Or is it even possible to tell that?
That's a very interesting question, and I think it's a combination of both. I think that to begin with, we've been blessed as a nation to not have had, in the initial period, a large number of persons presenting with COVID. But beyond that, the lockdown has played a tremendous role in ensuring that the spread was contained and that less persons were exposed. So to your question, I think it's a combination of both things.
Okay, thank you very much. Appreciate that.
Okay, now let's talk a little bit about the clinical management phase, which is point 2. Who should we start with?
Right. Well, I will start with the clinical management aspect. The very first aspect of it has to do with preventing becoming ill. It's about looking after yourself so that we never have to see you as physicians and you can continue with your life. Now, this virus is a very sinister creature, and the information that you hear now, don't be surprised if within another couple of hours it's changed, because it's such it's a creature that the way it's presented in its initial phases, in its initial stages, over the following weeks, we've seen that we've had to change our approach. So let me first talk about isolation and why it's important to be isolated. There are a number of persons who may be COVID positive, with the coronavirus, who are asymptomatic, and we know that a lot of the spread of this virus is through asymptomatic spread. So it's important for these persons to be isolated. This aspect of social distancing, being away from persons who, you see, my philosophy is that everybody's coronavirus positive until proven otherwise. And so you stand the best bet of ensuring you're not carrying or you don't contract the coronavirus by isolating yourself. The asymptomatic carrier and the potential remains the cornerstone of the spread. It continues to be the cornerstone. It's very important to continue to practice social distances. The virus is carried within the air in two different ways. You have in the one that we learned about initially when it was first out through droplets. We learned that these large particles containing the virus is spread when a person speaks, a person coughs, a person sneezes. And we learned that the particles moved between 3 to 6 feet. Now we're learning even more that contrary to this droplet theory, there's another mechanism through aerosolization and aerosolized spreading of the virus through a larger to a larger distance. And so some studies have shown the virus being spread in the air to 20 feet. In fact, recently I read a study to 30 feet. We don't know, and this virus is slick. So for that reason, stay away from any potential of spread. So that's the part about isolation and particle spreading. But then there's also the aspect that we've been talking about from day one, being practice hygiene that requires you to clean surfaces, ensure that your hands are clean, you wash your hands with soap. The virus, because of the nature of the envelope in which it's encased, it's very fragile to soap. So just by having the soap and water and just washing your hands 20 minutes, 20 minutes, for 20 seconds, as we've all been taught, keeps the virus from spreading, from surviving. And so that is very important. If you don't have soap and water, then there's hand sanitizers and alcohol preparations to get rid of this virus. My colleague, Dr. Cummings, liked to say, where there is soap, there is hope. So always keep some soap and water with you. Use your masks. There are different kinds of masks, and there's a question that's been asked about masks. Masks serve two purposes. One, and the primary purpose for mask is that it keeps the people in your surroundings from contracting whatever you may have. So when a patient sneezes or coughs into the mask, the particles, these droplets, are caught in the mask themselves and keep this from spreading to other persons within the surroundings. So the regular cloth mask, of course, different masks of different integrity as it relates to the percentage of virus that it can keep back. So you see persons wearing the regular cloth mask, and depending on the material it's made from, depending on how many layers, it can be anywhere from keeping 51 to 57% of the virus from actually coming in. But more importantly, it keeps the virus from going out and spreading to others. And then, of course, you heard about the surgical mask. There's a regular surgical mask. This surgical mask, again, keeps the virus from spreading to your neighbor, but to some extent, you get some protection as well. The important one is the N95, and you've heard about the N95 mask. And the N95 mask is particularly used within the healthcare facilities. It's the one that protects the healthcare workers most significantly from the virus that may be within the atmosphere. Viruses that could be spreading from the patients that they see. So we try to reserve the N95 for the healthcare professionals, for my colleagues, and for otherwise. But it doesn't mean that you, as a person within the street, can't wear an N95. But we try to keep those for the healthcare workers. I think that's the first aspect of it. Sure. Isolation, keeping yourself, distancing yourself, remembering that the virus can live on surfaces and various surfaces for various periods of times. And various studies have shown, for example, that the time it lives on wood is not necessarily the same amount of time that it would live on metal and on other surfaces. For all intent and purposes, every surface has the virus until cleaned. And so it's important that you clean your surroundings and practice good hygiene and good social distances and wear your mask, especially when you're interacting with other persons within the public setting.
Before we move on to Dr. Archita and Dr. Gay, I do have a question. So you have the surgical type masks that are disposable.
Yes.
And then you have persons who are wearing masks that are made. How often should those masks be washed?
That's a good question. So the disposable one, no washing, throw them out. The cloth mask. They offer protection, as I mentioned earlier, against the other persons around. It is advised that these be not worn beyond a reasonable time, is like 4 to 8 hours. Then wash them.
Okay.
You don't want to be constantly wearing a potentially virus-soaked, potentially virus-infected piece of cloth around your face. So wash them, have them ironed if possible, as subject this virus to heat if possible, and then you can now again wear it again.
Okay. Thank you very much for that. Dr. Archita, you would like to add to when we talk about clinical management?
Yes. We are probably, before we go on to clinical management, I would like to expand on what Dr. Jefferson just mentioned. Infection prevention and control are the key or the cornerstone to prevention of any infection, and
Right.
COVID-19 is no exception. And Dr. Jeff has already talked about what needs to be done in the community, and I'm going to just briefly talk about what needs to be done in hospitals. So all hospitals have an infection control and prevention policy and protocols in place, and I'm sure all of us have now modified it in the context of this pandemic, so to have specific areas to be addressed because of this pandemic. Now, this is a wide arena, and infection prevention and control starts at the very onset before the arrival of the patient to the hospital, and therefore communication, I think, is a very big key here. So I previously mentioned that individuals who think they have some acute health concern should ideally try and get in touch with their physician if they already have a physician, who they see, whether it is their private practitioner or it's a hospital physician. So call ahead so that we can guide them as to where to go. If they have COVID-related concerns, we can, before the patient arrives to the hospital, we can plan out their journey into the hospital and through the hospital. So communication between physicians and the emergency team or the triaging team, so that they are aware that the physician knows that a patient is arriving and can guide the triage team, saying, expect a patient with COVID-related symptoms. Communication between the first responders and the EMTs who bring in patients and suspect COVID-19 to forewarn the hospital to which they take the patient to. And of course, between hospitals when patients are being transferred. So that itself helps starting or initiating the process of infection prevention and control. After the patient arrives to the hospital, obviously if this patient has respiratory symptoms and is able to tolerate a mask, that is very advisable. So this would help source control, where we are able to provide the person himself or herself with a mask so that when they cough and sneeze, we are not spreading the droplets. Other than that, we also define segregated waiting areas for if there's a large number of people waiting to get addressed for their respiratory symptoms. We, if possible, separate the point of entry to the hospitals, for people who are coming in with COVID-related symptoms and those who are not. And of course, standard precautions are in place. So what Dr. Jefferson already highlighted is also applicable to any healthcare setting, where we, of course, practice good hygiene and cleaning of our surroundings and maintaining a distance or a safe distance. So standard precautions are always in place in any hospital. And for COVID-19, there are certain transmission-based precautions that we all need to take. And as he's already highlighted, these would include droplet precautions, contact precautions, because it can spread from surface or contact to skin, and airborne precautions, particularly in the scenario where an individual who's come in with respiratory symptoms is now requiring some form of therapy, which involves generation of aerosols, like even nebulization for that matter, or intubation, bronchoscopies, endoscopies, any invasive procedures, which may lead to generation of aerosols. So these are the transmission-based precautions which are put into place in all hospitals. Of course, a very important decision is a quick assessment of a patient who comes into the emergency or walks into the hospital and deciding about where the patient is placed. So designating an area where a COVID-suspected person would be placed in the hospital, which is already in place in all hospitals. A transport within the hospital has to be defined. How does that happen safely so that if they have to go for a lab test or they have to go for a radiology test, how does that transport happen without exposing others potentially to this infection? And of course, visitor restriction policies have to be put in place by an infection prevention and control team. And environmental cleaning and decontamination are very important aspects, of course, of infection prevention and control in a hospital. So decontamination of medical equipment, of the patient rooms, cleaning of the linen or handling of linen generated for the patient care, and of course biomedical waste management. So this is all a part of what we do, and I say that from personal experience because I had the infection control team at Health City. So these are aspects that I'm sure all hospitals are putting into place to ensure safety of patients. And of course, we also define how samples would be handled if patients with COVID-19 are tested or sampled for, swabs are taken or other tests or other secretions, body fluids are collected for testing, how they should be safely handled to prevent transmission within the hospital. And of course, the very important aspect of liaison between any private sector hospital or a government sector hospital and the public health department. Mm-hmm. So when we suspect a case or find a case to be positive, we interact with the public health team so that appropriate contact tracing can be done, and so that other preventive aspects can be brought into action, both within the hospital and in the community. And not to forget that training is the cornerstone. So training of healthcare personnel, especially in context of this infection. So for their safety, for training them how to safely wear the appropriate, and of course defining the appropriate personal protective equipment that they need to wear in each case scenario, how to safely put it on, how to safely put it off and remove it without contaminating their hands, their skin, or their respiratory tracts, is a very important aspect of infection prevention and control. And I'm quite sure we're all, having a field day doing all of these things all together. Mm-hmm. Staff safety is extremely important, the safety of healthcare personnel. As you may understand, these are a very limited resource, particularly on an island, and so their safety is paramount. So defining, their exposure risks, defining when they should be quarantined if they start developing symptoms, their testing, is all a part of what we are trying to together do as for the prevention and control of this infection in the hospital. I think beyond this, Dr. K might want to start speaking about how we clinically manage, because I think that's what we are trying to get to.
I do have one question before that, though. Obviously, all facilities have increased the amount of disinfecting that they do. Has there been a need, though, to maybe change the type of agents or chemicals that you use to do that process, to go through that process?
To be honest, no. So like Dr. Jefferson already mentioned, it's a very fragile virus, although a very notorious one, but very fragile. It's an enveloped, kind of virus. So it's susceptible to common household cleaners, including detergents, bleach, and of course to quaternary ammonium compounds that we use. So there are a list of even to alcohol concentrations of more than 60%. Yes. So we have, the hospital-grade disinfectants are very well, approved for the use against this virus. So
while
there's not been a significant shift.
No.
While health officials are testing, people at home should probably be cleaning.
Exactly.
Correct.
Okay. All right, Dr. Gay, if you can.
Yes. When the patient, Dr. Achita and Dr. Jefferson certainly have done a comprehensive overview of how the patients are managed from the community to the hospital setting. When the patient arrives at the hospital, indeed, we set up a triage where risk assessment is done, and that allows us to determine how we dispose of the patient, whether the patient is a patient with mild symptoms, for instance, may need to be advised and sent home and monitored at home. And certainly we need to be sure that that patient is in a setting or situation at home where they're able to do that reliably. One of the characteristics of the condition is that deterioration can occur quite rapidly, sometimes in patients that have minimal symptoms. And we want to make people aware of what deterioration means. So when we send someone home, we want to link them with a general practitioner in the community, and certainly make public health, the public health department aware of their presence, and they will be checked frequently by the public health department. So patients need to know that, if they've got an increase, if their cough starts to increase, or they're, getting dehydrated, unable to drink and maintain proper hydration, that they should call back or, seek medical help. Certainly patients that have comorbid conditions, patients with high blood pressure, diabetes, patients that are of advancing age, they need to be particularly cautious. And certainly when we have patients with perhaps mild disease and they have other conditions as well, sometimes, although the respiratory aspect of the condition, their cough and cold and so on may not be too severe, it's still quite important that that we know what's going on with their other aspects of their health, and sometimes that alone may trigger our sensitivity to get these patients under monitored care and admit these patients. So that's certainly where that's certainly where the triage comes in, when the triage at the hospital comes in. And of course, patients with moderate symptoms, they will require admission. Patients whose oxygen levels are deteriorating, we want to make sure that these patients don't get to the stage where they need oxygen. Well, they may need oxygen therapy, but they may go on to requiring ventilation support, and that's certainly where we want to avoid ventilation, but we're certainly not doing it as in the stepwise fashion that we are accustomed to, because we've got an airborne agent, a virus that can cross-contaminate other patients and staff as well. It's important that we don't do procedures that are going to put these staff members and other patients at risk. And one of the things we often would do is non-invasive ventilation, which is where you support the the patient with oxygen under slightly higher pressure, so that they don't have to breathe as hard to get the oxygen in. And this makes it's very difficult to do without having leaks around the masks that are used and so on. And we have to be very cautious how we go about this, and that we do it in the right setting, if we do it at all. And it's for that reason that the COVID patients, one of the guidelines was initially certainly is to intubate the patient as soon as that level of deterioration occurs, and then you put the patient on a ventilator. That sets up a whole new level of management, and we're talking critical care management here. And so someone coming in with very low oxygen levels, with a bad cough, and we do our checks, and we suspect this patient has a pneumonia, we would want to be very sure that this patient gets the right care. Yeah, you will hear of patients going home with mild pneumonias, but that would be the very fit and well, and otherwise fit and well, not somebody who is old or who has got other medical conditions that need attention. and certainly would need to be under close supervision at home. So the triage is very important on arrival at the hospital, and that we and the doctors must be very wary to ensure that patients go in the right departments. So.
Okay. Before we move on, we do have a question from Wendy at CNS. Wendy, please go ahead.
Thank you, Donna. I've read a lot of different things about what people suffer when they get coronavirus, and the symptoms seem to be so far-ranging. I was just wondering if any of the doctors could tell us, in their experience, whether they've seen such a variety of symptoms in patients that have all got the same common virus. So, I mean, you've heard about people being fine, but they've lost their appetite, they've lost their sense of taste, or people who, even blood clots, I understand as well. I mean, it seems that people get really different symptoms, and I just wondered if they could share with us other viruses that they've seen that are like that.
Right. So I could thank you very much for that question, Wendy. I think I will speak to the experience from the experience at the HSA. Even with the limited number of patients who've come into the HSA, they've come with a wide-ranging variety of symptoms, and that's what makes it so difficult to understand this virus. We had one patient, for example, who came in, and his pulmonary function, his lung function was so terrible. And based on what we learned from Italy, we thought, wow, this is a problem. There is significant bilateral, what seemed to have been bilateral pneumonia. But in addition to that, there were a number of other things going wrong at the same time. So this virus was attacking several different organ systems at the same time, including, as you mentioned, Wendy, blood clots. So the patient had massive blood clots within the limbs. And we thought, well, it seemed, things didn't look right. The end of that story is that the patient, fortunately, recovered from the pulmonary issues, was started on the appropriate medication, and we managed to resolve the clots. But based on the presentation, the long presentation, without going into a lot of details, the patient's blood studies looked significantly worse than the patient himself looked, if you understand. So when you look at the blood oxygen and the blood oxygen concentrations that we were seeing, it was ridiculous. But the patient looked a little bit better than what is showing us. So there are a number of questions, Wendy, as to how this virus presents differently in different individuals. On the other hand, we've had other patients who've presented with bowel symptoms, with abdominal symptoms, abdominal aches and pains and cramps, and with very little pulmonary problems. And from the literature, even in the patients with pulmonary problems, we've had different types of pulmonary problems, and so much so that they've classified the type of lung presentation into different subcategories. So the virus presents differently in different individuals, and a lot of studies now being done to try to find out, to sort of decode why it is that there is such a wide variety of presentation. And I can't, I'm not a virologist, but I can't remember seeing any other virus that is so sinister and mischievous.
I'd like to expand a little bit on it. So being a pulmonologist, usually I've always seen that these kind of respiratory viruses would usually affect mainly respiratory symptoms, the system, and of course with the flu-like illness. So, these could be vague symptoms of body aches, fever, low-grade fever, loss of appetite, loss of taste, and of course respiratory symptoms like cough, sneezing, sore throat. But this virus really, in my limited experience too, has shown us a wide range of symptoms, including abdominal symptoms, including just nausea or vomiting, including diarrhea. There are also some people with mild neurological symptoms, which, I have had one case where I've noticed that this is a problem. And of course, there are case reports from world over where there can be cutaneous manifestations or rashes produced because of this virus, neurological symptoms, and in certain Italian subsets, there were patients with Guillain-Barré syndrome or what you call neuromuscular weakness, which were reported. So it is really a virus which is evolving, the knowledge is evolving, and it's difficult to say how it may manifest.
Yeah.
Okay. Wendy, does that answer your question there? Is that enough info?
Yeah, I have some more, but I don't know whether other people want to go before me.
You can continue on, and then we'll go to the others.
One was about the call. I don't know who could answer this, but really, how have the hospitals been collaborating to make sure that everybody's on the same page? Are they going? Is there a policy document that everybody's following, or what are the guidelines for that?
Can you see this, Wendy?
She can't see it.
Oh, you can't see.
But
I can't see anything.
So unfortunately, you can't see this, Wendy. But sorry. Right now, I am showing a document, and it's entitled "Cayman Islands COVID-19 Clinical Guidance." And essentially, this is a document that was put together by a collaborative team of doctors. The members of the government asked at one stage for there to be a collaboration. And of course, the collaboration was going on even before then. I mean, from the onset, the physicians felt the need to collaborate. So we have a number of WhatsApp groups and persons who scan. It's like you have these physicians who are scanning the literature, coming up with the new ideas. And in fact, there are a group of physicians who they've dedicated their days to look at what's going on with respect to the new information relating to ventilation and ventilators. We have another group that's looking at other aspects of oxygen therapy, other aspect of therapy, other aspect of medication therapy, the clinical management. And as soon as the new evidence is made available, then there are changes that are made. So this document that I showed just now, which is the most current document that came out of the collaborative efforts of the various physicians, even this document changes. One of the very exciting things when we're putting it together is that from day to day, we felt we had to go and adjust things and make changes as new information and new evidence comes out. So that's where, as a nation, we are very fortunate. We are very blessed because we have a group of physicians who are passionate to ensure that the patients in the Cayman Islands are obtaining the best benefit from the research that's available. I remember when we had our first patient on ventilator, I was swamped with ideas and opinions from the colleagues because they didn't want our statistics they didn't want our patient to be a statistic. They wanted to ensure that we use all the available evidence that was there to the benefit of this patient. And so that's the beauty of the collaboration that we're now seeing amongst the physicians.
Wendy, any further questions?
Just a couple more. One of the ones that I would like to know is what's happening now with the malaria drug, because I understand now that there's studies saying that it really isn't of any assistance, and I just wanted to check whether we'd use that at any time or not. And also, generally, what are the biggest challenges that they're still concerned about, the physicians in general? And that's it. Thank you.
Dr. Archita will
Yes.
answer your question, Wendy.
I will be answering your question shortly, Wendy, because I am going to talk about medications shortly and the current evidence.
Okay, great.
But let me just forewarn you, it's a very changing and evolving science right now. the medicines, the guidelines, and the recommendations are changing on a day-to-day basis. So I will try and cover that shortly.
Right.
Yeah.
Okay, Wendy?
Okay, thank you. So just the general question at the end, really, if all the doctors could just let us know what they see as the biggest challenges that they're going to face.
Okay. We'll get to that at the end. So moving on under the topic of clinical management,
Right.
Dr. Jefferson.
Right. So I will be spending a little time to talk about ventilation. Now, my colleague, Dr. Gay, spoke about the initial management of the patient. We hope, as physicians, we never want to see our patients deteriorate to the point where we have to take over their management, their ability to breathe. I am a clinical, an intensive care specialist. And one of the things, well, in fact, all three of us here have a critical care management experience. And I'm sure I'm speaking for them as well as for the other clinical care specialists that one of the most disturbing things is when you have to take over the breathing. And from time to time, we've had to do that. With the coronavirus, luckily, fortunately, most patients are asymptomatic. A few patients have mild symptoms requiring no support, like Dr. Gay has said. But then there's some that we need to assist with providing oxygen. The virus attacks the body's ability to adequately provide oxygen to the organs through a number of mechanisms. And so at times we need to augment this oxygen delivery. Sometimes it's only a nasal cannula with oxygen that is required, as you heard earlier. Sometimes just a face mask providing oxygenation. But there is the unfortunate situation in which the patient needs more than that. They need some sort of a support. Now, there are two types of support. You have what's called the non-invasive ventilation, where we do not put a tube down the patient, but we put a mask on. Now, earlier in this pandemic, it was the recommendation that you do not use a non-invasive mask. So this is just showing how the evidence has changed over time. Because by non-invasive ventilation, Dr. Gay mentioned the fact that you don't really get a tight seal, and so the virus is able to escape around the mask. So the non-invasive method of putting the mask on was not recommended. What was recommended was early access to the airway, early intubation, early ventilation, and what they were finding in those cases was that there was a better outcome. Mm-hmm. Now things have changed. Now they are recommending that you only intubate if you absolutely have to. There are two schools of thought. One school is early intubation. That was the earliest school. Early intubation, put the patient on the ventilator, ensure the patient gets adequate oxygenation, and earlier you do it, better the outcome. Avoid non-invasive ventilation with CPAP machine. It's used only in certain indication, patients with some particular disorders, because of the generation of aerosolized what's called bioaerosolization. Now they're saying avoid intubation for as long as you can. Only intubate and ventilate. Only use a mechanical ventilator and in an invasive manner if you absolutely have not been able to secure a patient's oxygenation through face mask, high flow nasal cannula, CPAP, non-invasive ventilation. Only then do you go on to ventilating. Now, I want to put a caveat onto that based on our experience. One has to manage the patient that's in front of them. And some patients will do better with CPAP, with the non-invasive CPAP, but some patients will definitely, and we found that in our experience, will definitely need to be put on the ventilator, because unless you do that and take over the the work of breathing unless you provide them with a mechanism where you can now provide them with adequate oxygenation at a moderate force, then they will not be able to provide oxygen to the essential organs that's needing it. And so I just thought I'd talk a little bit about that. I'm going to be passing on to Dr. Archita for her to speak to Wendy's question about the other clinical management using medication.
Archita?
Thank you. So as Dr. Gay and Dr. Jefferson have already pointed out, the mainstay of therapy for patients affected with COVID-19 is supportive care. So it's already been highlighted, oxygen therapy, hydration, if their blood pressures are low, what we define as septic shock, we give medications to support that, to bring up the blood pressure, to maintain perfusion or blood supply to vital organs of the body. Use of antibiotics where it is relevant. So if there is a secondary infection, because you may understand when the lung is afflicted, there can be secondary bacterial infections. So use of antibiotics in those circumstances. So these are all part of drug management in any patient who's critically ill, who needs treatment. And there is no recommended or approved therapy for COVID-19 at this time. So, and the science is changing every day, like I mentioned. So we have drugs which have shown promise, and then there have been trials based on them, and then they have shown lack of promise, or the side effect profile hinders their use in a general population. Mm-hmm. So this science is really evolving. And just to outline how drug therapy is being defined or being thought of for the treatment of COVID-19 is based on two aspects. One is the antiviral category, where we try and suppress or kill the virus. And there are certain treatment modalities being put to test or being considered, which are immunomodulatory. So it modifies the response of the person who's affected by the virus, or the host, as we may say. So antiviral therapies, there was initial data from Wuhan and China, where there were drug trials of certain HIV drugs, like lopinavir and ritonavir, which had shown some promise, either alone or in conjunction with other medications. There have been trials with another agent called ribavirin. There have been, of course, trials with chloroquine or hydroxychloroquine, which are classically not antivirals, but they prevent the entry of the virus into the host cell, so to say. And that is the potential mechanism of action. And there have been various studies. There was quite a bit of encouraging data initially, and therefore you may have heard of all the news channels filled with news of how hydroxychloroquine or chloroquine phosphate could be used as an agent either alone or in combination with a common antibiotic we know as azithromycin. And that has been part of our recommendation as well. However, this has to be decided on a case-to-case basis, because every medication comes with its side effects. And we must understand that people who are critically ill and are usually individuals who also have comorbidities. And so they may be very susceptible to the side effects of these medications, particularly people who have cardiac illnesses or who have certain electrocardiographic abnormalities may not be a candidate for this kind of therapy. So there was an initial, encouraging data, like I mentioned. Just 2 days ago, I think, or 1.5 days ago, there has been some data published by the National Institute of Health, which has shown, which is probably recommending against this treatment, based on a certain trial. However, the data is still very fluid, like I said. So it's very difficult to comment. And most of these treatments are being offered in most countries as part of a trial, so that when we use these experimental agents, we look at the data as to these are the individuals we treated with the drug and these are the individuals we did not, or we treated with an alternate agent, and what were the outcomes. So this is a scenario in which most of these drugs have been tested or tried, and we are getting more and more information. Antivirals also include a drug known as remdesivir, which is an experimental agent right now, and there is this was the study by Gilead Sciences, and there is some encouraging data. But again, it's too premature, so we are not going to be able to say what is the right line of treatment. However, as physicians, as clinicians, when pushed to a corner where we have to save the life of our patients, I'm quite sure we would be able to take some decisions on a case-to-case basis. And there is a consensus among the medical community at this time about management of such cases. I would like to also briefly touch upon certain agents which are immunomodulatory agents, which are being considered for this therapy or treatment, which is, there has been some talk about interleukin-6 antagonists. So just to make you understand, what are immunomodulatory agents? Now, the virus enters your body, it affects the cells. The cells in the process, or they recognize that this is an abnormal agent and it's trying to do some damage, release certain toxic chemicals to kill the virus, so to say, and these are known as cytokines. And when these are released into the body, there's a battle here, right? So these chemicals are potentially toxic to the body itself. And as a result of which, we have what we know as severe inflammatory response to the infection. And of course, the body's or the host's response to it. And this can lead to certain really bad outcomes or organ damage. So sometimes to suppress the severe inflammatory reaction, there are certain agents which suppress these cytokines, so to say. So there are agents which are which are potential candidates, like interleukin-6 is one of these cytokines, and there are agents which antagonize its action, which are under trial. There is some talk about interleukin-1 antagonists, interferons, but the data is very limited, and really right now probably the risk profile may be a little more as compared to the benefit profile. And there are other experimental agents which are also being considered, like anti-helminthic agents. These are agents which are used for the treatment of parasitic infections, like ivermectin, nitazoxanide, but it's too premature to say whether these would be effective. Most of the data that we have right now is from lab studies, where we have seen that these drugs can be effective in a lab model, what we know as in vitro activity against the virus. And there is, of course, some thought, and there are trials in place for what we know as passive antibody therapy or convalescent sera, where those individuals who have recovered from the infection would have developed antibodies to the infection, or developed immunity, as we understand, to the infection. And this kind of therapy, where we use passive antibodies from an individual who has developed this immunity, take the serum from that individual and transfuse it to an individual who is, acutely ill with the illness, may show some potential. This is not a new science. We've had this kind of treatment being tried for more than a century, I'm sure, and it has been tried for other viral infections of a similar nature. Again, this is subject to trials. We don't have sufficient data to say whether or not this is a good form of therapy. I think we have made a proposal saying that we can have our own trial if it comes to that. But for that, we would primarily need some antibody testing, a reliable antibody testing to be put in place before we can do that. So we do have the equipment and the knowledge to put this kind of treatment into place, what we know as plasma apheresis machines, etc. So this can be done. We also have a study proposal at this time, but it is, of course, not subjected to not been submitted for approval yet, because we've not really reached that stage yet, and hopefully will not.
Hopefully not.
I would also like to briefly mention that we have facilities, as an expansion to ventilation, because we said the care is mainly supportive, and the primary aim is to maintain oxygenation, so as to be able to perfuse, for the body's organs to work. And when ventilation does not work or fails in some individuals, we have on island the facility to, to provide such patients with extracorporeal membrane oxygenation, or ECMO. So Health City, I think, has 2 or 3 such devices. We have 3 such devices where individuals who have failed to respond to ventilation or are not doing well, despite all the manipulations we can do with ventilation, all the methods we can put in place, like proning or flipping over, or adjusting the settings on the ventilator, and we are failing to do any good to the patient's ventilation parameters, then there is a backup where we can consider ECMO, where the blood is circulated through an oxygenator, and this does the job of the lungs. So this is also a treatment modality which we are fortunately, we do have access to on the island.
Okay, that's great. I think we have a question from Kayla, and then we're going to begin wrapping up with final thoughts. Kayla, please go ahead.
Hi, I wanted to step back to a data point that was provided earlier about that slightly more men have been affected. I think it was 53%.
5248.
I'm 5248. Thank you for that. Are we seeing that more men end up hospitalized as well? And is there any sense as to why men might be slightly higher in terms of representation?
Right. So to your question, Caleb, yes, there are more men of the 11 patients hospitalized. Most have been men. Definitely, of the 3 patients requiring critical care treatment, they've all been men. They've all been male patients. Unfortunately, males are, for some strange reason, I'm not too sure why, and I don't think anybody has been able to figure out why. But the males in Cayman, as is the case in several other parts of the world, seem to be having a more severe condition, a more severe presentation. Yeah?
Okay.
Thank you.
Okay, Kayla. Okay, so if we could ask the panel to wrap up with any final thoughts or any further information for our viewers.
Thank you very much, Donna. And it's really, I must say, it's a pleasure to be able to address the country. As I said earlier, it's our intention there are two purposes. One, to bring hope, to have the country understand that we are at a point where we're seeing something that most of us have never seen before, and hopefully we'll never see again. There is a virus that's here, and it's real, and there's a lot of talk about conspiracy theories, but the reality is that those of us who are in the clinics, we see the reality of its manifestation. And so it's to bring hope to the country, to say, stick with it, stay at home if you can, wear a mask when you can't stay at home, protect the elderly and the vulnerable and those persons who are most at risk, and basically help us so that we can better help you. Also want to give a big thanks to the government for being proactive and implementing some strategies that they've implemented. But I also want to give a big thank you to my colleagues who have all been very engaging and very cooperative, and who have put a lot of effort into, I mean, day in, day out, you see Dr. Lee, of course, he's taking a break from the cameras today, but days in and days out, you've been hearing, the updates being presented by the government and by the medical team. And I want to say a big thank you to my colleagues at the HSA who have put a lot of work into ensuring that the data is available, and also to my colleagues at Health City who have come on board and said, yes, what can we do how can we get involved, and to the colleagues at Doctors Hospital and in the Medical and Dental Society. And there is this unity that I am hoping will continue amongst the physicians. So the country can hold on to the fact that we're in a fight, it's a war, but we have put structures in place to ensure that we'll come out victorious, and very few, if any, casualties will be left behind.
Dr. Archita, any final words?
I completely concur. Nothing more to add.
Okay, Dr. Gay?
Yes, I think Dr. Jeff has done a very good job of summing up, but I do think this has been, the coronavirus pandemic has allowed our medical community to collaborate quite extensively on the issue, this particular issue, and I think the bonds that have been created out of the coronavirus pandemic have been very much strengthened, and we look forward to keeping the public abreast with new information as it comes to light. And I think Cayman is very fortunate that we have connections to, with doctors with connections all over the world. And as soon as new information arises, someone in the medical community is quite quick to pick it up and pass it on. And I'm sure that will continue for the benefit of the population.
Okay. Well, thank you very much to you, our panelists, for being here today. We thank you, the public, of course, for joining us for this special Q&A with the medical team from the various hospitals here on the island. We invite all of you to join us again tomorrow for our regularly scheduled press briefing at 2 p.m.
Blue serenity in yonder deep, the fear of death, but you pray, O Lord, for your soul to keep. Dear boredom, nothing but a selfish film over our eyes. Some people just don't get it. COVID-19 is a murderer, and your defiance reflects upon your character. Yes, I get it. Cabin fever is a breeding ground for depression, but I have a confession. Yes, you guessed it. We are in this together, and although our stories are not the same, they're similar enough to understand the pain. Read a book. Engage your mind. Don't give negativity the time to fester. Don't let it rule you so that Cayman too can see this through. Those beloved smiles that we shared with friends doesn't have to end, but you are consumed by what you do not have. When the health of Cayman is in your hands, there are many without work. They can't go to Kirk's in a panic, worry about organic. Premier says to live frugally so that repercussions don't hit so brutally. Read a book, they say. However, it is true. To discover something your mind never knew, educational absorbency in this time of uncertainty. Together, Cayman, together. Together, let's stay home, not just you alone. This is not a punishment, but a journey to success, to restore our faith in the human touch and the beauty of shared air. Together, we are a nation. Together, we are stronger.